So I'm going to talk about acupuncture in the management of lymphedema, and anyone who knows me knows that I'm passionate about acupuncture. I'm passionate about lymphedema, and so it's great to talk about this. And what I want to cover this morning in this presentation is a bit of an awareness session, and for some of you this will be a review, but maybe for some of you it will be new. So I'm going to cover what lymphedema is, how it's managed conventionally, and what some of the safety issues are. So the non-accidental and accidental skin puncture guidelines, and how that impacts our practice as acupuncturists. I'm going to review have a look at the published research on acupuncture in the management of lymphedema. And as you will see at the end of this, I have more questions than answers. I have no answers today on this, but I have a lot of questions and possible areas for research. So I hope that colleagues can pick up on these and develop this, because this is an evolving area, both in the conventional understanding of lymphedema and our research work. So there's a lot of scope for development here. So what is lymphedema? Well, Moffat et al. Tell us that this is a broad term used to describe edema that's been present for more than 3 months and is not relieved by elevation or bed rest. So we have two important factors here that differentiate it from normal edema, that it's chronic, it's at least 3 months or more, and that it isn't relieved as we would normally see in normal edema by elevation or bed rest. Foldy et al., who are the pioneers in lymphedema and understanding lymphedema, tell us that this is an accumulation of lymph in the interstitial spaces, principally in the subcutaneous fatty tissues caused by a defect in the lymphatic system, and is characterized by abnormal tissue proteins collecting in the tissue, edema, and chronic inflammation and fibrosis. And I've emphasized this chronic inflammation and fibrosis because certainly within acupuncture, lymphedema is often thought of as a fluid pathology. And I really want to raise a question that although that may be part of it, there is also something going on here with the inflammation and fibrosis that's very important to address. Now, lymphedema is a progressive condition, and as you can see here, the International Society of Lymphology have a staging system. They've recently, it started 1, 2, 3, they've recently added 0, because subclinical lymphedema is now seen as an important point where intervention can really minimize the problem. So if you get in early, you can make tremendous differences. And here we are asymptomatic, but there are changes going on in the tissue and fluid composition. Stage 1, we see an early accumulation of fluid, and we can see here that already that there's a tension in our definitions, because the ISL tell us that this subsides with limb elevation, whereas Moffat said this does not generally subside. And we have pitting, so if you press your finger into it very hard, the tissue does not have the elasticity to respond. And you can see this develops at late stage 2. You start developing the changes in the tissue. So you get excess fat and fibrosis. So you have a change in the structure that even if you drain the fluid from there, the structure is compromised. And then stage 3, where you have some really severe skin problems. Now, lymphedema occurs anywhere on the body. I've chosen some of the more acceptable illustrations here, but you can see that this is a disfiguring, a disabling, and a very distressing condition. So the clinical notes are that it is chronic, okay? It is progressive, so it needs management, and ideally that is managed by a professional team. And it's currently regarded as not curable. So once you've got this, you've got it for life. It's very, very poorly understood. Developments in lymphedema, I think, probably started with the Foldies in the 80s, and really the impetus for research and understanding has really started since the turn of this century. So it really is picking up a pace. It often goes undiagnosed. Often clinicians in the community do not understand it. It's often mistreated, or often it's not treated until it's advanced, and then it's far too late to start pulling it back. Some important characteristics are that it improves with exercise, and it's not improved by diuretics. So again, we have this idea that this is not necessarily a fluid pathology. And something that I think is really important is that it fluctuates. So some people have intermittent periods where they are asymptomatic. And I think this needs also to be, when we're doing research, we need to recognize that and somehow deal with that. Looking at lymphedema generally in an umbrella term, it's classified, it has two classifications. Primary lymphedema is a congenital condition caused by abnormalities or disease originating in the lymphatics. And secondary, which is the one that's going to concern us this morning, is when you have external trauma to the lymphatic systems. And this can be caused by surgery or trauma or disease. But there is a theory that lymphologists hold that all lymphedema may be primary, and that those people who develop secondary lymphedema really are predisposed that way because there is some congenital imbalance. And I've put this slide in just to demonstrate how rapidly things are developing in the understanding of lymphedema. So with regard to primary lymphedema, historically there were three categories: congenital, precox, and tarda. And then in 2010, Connell et al. Published their paper where they had identified 6 main diagnostic categories and 20 subcategories. So you can see that this is a rapidly evolving field. Turning our attention to secondary lymphedema, worldwide, the most common cause of lymphedema, or the most common type of lymphedema, is filariasis, which you see here, this very unpleasant condition caused by this innocuous little mosquito who carries a virus and in the tropics gives many people that. But in the developed world, secondary lymphedema most often results from cancer and its treatments. It's associated with surgery, and many people will know that, particularly lymph node excision, but it's also a consequence of radiotherapy and some chemos. So we're finding out that taxanes will cause lymphedema, and often in different parts of the body. So breast cancer patients will get lymphedema of the lower body. So this is getting very complex. And something that's very important is that it may occur soon after cancer treatment, but often it can occur many, many years later. And this is important for our understanding of risk. Patients who don't develop lymphedema are said to be at risk of lymphedema if they've had these cancer treatments, and that risk is a lifelong risk. So looking at the incidence of cancer-related lymphedema, and as we go through this slide, we'll see that there's a huge range of understanding in the papers. So we really haven't been able to target how common a problem this is. So if you look at the literature for breast cancer-related lymphedema, you'll see papers that cite anywhere from 3 to 89% of breast cancer survivors will get lymphedema. But the rule of thumb is that about 1 in 5 breast cancer patients will develop lymphedema. For the gynae cancers, it's about 1/4 to 1/2 of survivors. The melanomas, it depends which part of the body, but up to 40% for those with axillary lymph node surgery, and about 2/3 of those receiving pelvic or inguinal lymph node surgery. About 1/3 of sarcoma patients will get lymphedema. 10 to 40% of head and neck cancer patients will get lymphedema, and head and neck lymphedema related to head and neck cancers is the exception that proves the rule, because this is a lymphedema that will usually resolve in the majority of cases, although some people do go on to develop chronic lifelong lymphedema. As I said, it's a lifetime risk, and it may often, with breast cancer, the most cases occur in the first 2 years after treatment, but there are patients who come in 20 or more years after with lymphedema after treatment. So what are some of the problems associated with lymphedema? Well, the lymphedema itself is swelling. As you've seen on the previous pictures, there is a condition, a risk of acute infection, and I'm going to talk about this later. When advanced, it can weep, and so you have lymphorrhea, and it's associated with deep vein thrombosis as well. More interesting for me as an acupuncturist and a person interested in overall well-being of cancer patients are the consequences for physical and psychosocial health. So there is pain and discomfort associated with this. You can imagine that if your limb is swollen and you've got 10 or 20% more fluid in there, this becomes heavy, it becomes disfiguring, hard to manage your limbs, and particularly in the lower body. Patients with lymphedema often get very depressed. They are often very anxious. How much is this swelling going to keep continuing is often a concern. There are sleep problems, physical disability, obviously, as you've seen from the pictures. Obesity is highly correlated with lymphedema in two ways. The change in the tissues creates more fatty tissue, but also people who have high body mass indexes are more likely to develop lymphedema. There will be huge body image problems, problems with sexual function. It also affects adjustment to cancer diagnosis. So for breast cancer patients, lymphedema is said to be the most feared consequence of breast cancer treatment. This can have a wider range of consequences, including impacts on employment and relationships. So if we don't identify lymphedema early, and it's going to look at how it's managed conventionally, if we don't identify lymphedema early, then intensive treatment is required. In the UK, this is called decongestive lymphatic therapy. And you can see here it's a combination of this very intricate multi-layer lymphedema bandaging, skin care, exercise and movement, and a special form of massage called manual lymphatic drainage. And this is carried out for 2 to 4 weeks. It's a very intensive treatment, and it's followed by maintenance therapy. Now, in the UK, we refer to this as the 4 cornerstones of maintenance therapy, and all patients with lymphedema will go on this. And so the key thing is the external support and the compression garments here, which are currently seen by the lymphedema experts as being the most important way to manage swelling, but also skin care, exercise and movement, and patients are often taught how to do their own simple lymphatic drainage, and sometimes that is recommended that they do this twice a day. And for many patients, this is a regimen that they have to carry out every day for life. So this is a very onerous thing to have. We don't want our patients to have this at all. I'm going to look at skin care because this is where we start to this starts to affect how we practice acupuncture. So the skin care advice that's given to patients is that they should avoid any interventions that break the skin. And these include non-accidental skin punctures, so all your medical procedures, taking blood, injections, and blood pressure, oddly enough. And then you can see a number of accidental skin punctures, which really are part of daily life. I'm a gardener and a cook, and I'm usually covered with burns, scratches, and cuts. So this would really affect my lifestyle. Now, acupuncture is not the official lymphedema organizations do not contraindicate acupuncture for lymphedema patients, and I think that's important, but there are precautions that need to be taken. Now, the reason that skin care is seen to be important, there are 2 reasons, and the first one is the potential for developing cellulitis. And this is a potentially life-threatening condition. It has a very rapid onset and requires immediate medical attention. And patients, when they contract it, are put on antibiotics for 2 weeks. And it can require hospitalization. And if a patient has 2 or more episodes in a year, they're put on prophylactic antibiotics for 1 year. And I have treated a woman with lymphedema who was on prophylactic antibiotics for 10 years. So this is serious stuff. Now, cellulitis is interesting because people with lymphedema are more prone to developing cellulitis, but people who haven't manifested lymphedema may often manifest it after having an attack of cellulitis. So there's a circle there. Cellulitis can exacerbate lymphedema, and if you have repeated cycles of cellulitis, it leads to deterioration of overall health. The second reason why we are concerned about skin care and breaking the skin is that there's a concern that it will exacerbate lymphedema. And Cole, in 2006, this is still a seminal paper, talks about that you're putting a burden on a compromised lymphatic system when you put a needle into a limb, and that it may instigate swelling. But what is the evidence for all of this? Well, the International Lymphedema Framework, which sets international guidelines for lymphedema care, acknowledge that there is a lack of robust evidence for their guidelines, and they say that they reflect a common sense approach. Jeanette Jones, who is a lymphedema nurse specialist in the UK, recently did a review of the literature, and she concluded that the studies were poor, so there is no real evidence that supports that venipuncture is a factor in lymphedema, causing lymphedema. But she says that as a therapist, she asks patients to avoid skin puncture, as anecdotally she sees a lot of patients with arm edema following puncture of any kind who have not had any other trauma. So there's a lot of anecdotal evidence here, but not published evidence, because this is something that I hear from other lymphedema nurse specialists. Chang et al. In Australia wrote an interesting paper in 2013 where they reviewed the literature as well, and they concluded that there is a need for research from prospective trials on this controversial topic to determine the most appropriate recommendations. Now, obviously, there are implications for acupuncture if we have to avoid skin puncture. And I'm lucky to travel around, and I meet lots and lots of people who work with lymphedema, and so I come across a wide spectrum of opinion here. And probably at one end of the extreme spectrum is in the popular literature, there is a lot that says that acupuncture should be avoided by people with lymphedema. And there used to be a site here in the USA called Lymphedema People, and if you Googled acupuncture and lymphedema, it was the first thing that came up with this very strong statement that all acupuncture must be avoided by people with lymphedema. Moving along the spectrum, there are those who say acupuncture is okay for people with lymphedema if needling is avoided in the affected area, such as the arm, and Jacqueline Filshy's work documents this. And then where I work at Mount Vernon Cancer Center, if I want to do acupuncture, I need to avoid the affected quadrant on the affected side. So this is often seen as draconian, not just avoiding the arm, but the torso on the affected side. There are those who say that as long as you're using clean needle technique, acupuncture is safe. And then there are those who say that needling the affected area is safe and effective for treating lymphedema. And this is most notably the work done at Memorial Sloan Kettering by Castleth and her team, and also Mateki's unpublished work on this. But there's little, if any, evidence to support any of these positions. We have 6 papers in existence, 6 published papers on studies, and Mateki's unpublished abstract of her work. And some of the things that I want to just highlight here, the first thing is that we have a very international group of practitioners. So Kanekura worked in Japan, Alaman Gergel from Brazil, Castleth in the States, my own work in the UK, Caroline Smith's in Australia, and Jung in Korea. So we've got a wide variety of medical contexts here. and different approaches. And just looking at some of these, I have a list. So I've talked about just on these international approaches, to say the medical context are very different. So in my own work, we work very much with the lymphedema team. The patients that I've worked with are seen and managed conventionally, and acupuncture is an adjunct to their care. But if you look at the Allam and Gergel papers and the Jung papers, they exclude anyone who's having conventional care, and they're only managing this with acupuncture. So there's a very wide spread of approaches here. All of these papers are fairly recent, okay, and a lot of them in the last 4 or 5 years. They've made us focus on breast cancer. There's just Kaneka's gynae, and I've done some work with head and neck patients. And there's only one paper that explicitly states that they needle the affected area. We assume that Kaneka also needled the affected area, but that paper was published before the stricter guidelines for acupuncture reporting, so it's difficult to actually say what they did. We have very, very few patients enrolled on these studies. I haven't got the total here, but it is less than 150 patients. And we've got less than 1,600 treatments. So if you compare this to the the German JERAC studies, where they have thousands of patients and millions of treatments, we've got a little way to go here with lymphedema in developing the evidence base. There's also different approaches to needling, and so whereas I avoid the affected area and the associated torso, Cassilith needles into the affected arm, it's very interesting that Jung and Allam and Gergel didn't needle on any point on the body on the affected side, on the ipsilateral side. So there's a wide range of approaches here. And the other thing I would just like to say is there's only one RCT, and that's Caroline Smith's in Australia. So you can see we really are at the beginning stages of work here. And this is a very busy slide, and I just want to pick out a few things here. After I have a... We've got, just as we've got heterogeneous approaches to the studies, we've got heterogeneous measures. Most of the studies concentrate on reducing the arm circumference, but this is done in many different ways. There are many different ways of measuring. Allam and Gergel measured at 3 points on the arm. Cassilith measured at 2 points. Smith measures, I think, at 2 points or every 10 centimeters, and measures both arms, and they also do bioimpedance measuring to measure the extracellular fluid. When we work in the UK, we measure every 4 centimeters, and we calculate the volume of a cone. So all of our measures are disparate, which makes it very difficult to compare the studies. And we also have, most of the studies concentrate, as I said, on change in circumference or volume, but we've got some quality of life measures in there, and a range of those: MIMOP, SF36, PANAS, LSIDS AT, and VAS scales. So it's not easy to compare these studies. Safety is a key issue, and most of the studies will report something on safety. And the good news is, all of these studies are fairly conservative. The good news is that there are no serious adverse events. Mostly they are the usual mild and transient events, such as bruising or bleeding. But I just want to point out that in my study, in my study, we had 2 incidents of cellulitis, which were confirmed not to be related to the acupuncture. And Jung et al. Also had 2 non-acu-related infections in their small group. So, there is always the risk of cellulitis or infection, and we need to be able to discern that this is not acupuncture-related. And most people report that the swelling does not worsen with acupuncture, and I have to say that on our study we actually had 2 people whose swelling got worse. And again, this was confirmed by the lymphedema nurse that this was not due to the acupuncture, but to the patient's own self-care regime. So it's complex, and it's good to have professional lymphedema specialists on your side when you're doing these studies. A very quick look at the points that are used, and Kanakura, Ellerman, Gergel, and Kasselith used a fixed protocol with those points. These 3 studies all use, they either have a core protocol with some added individualization. This is the one that I used, but I've used a very wide range of individualization in my study, and I haven't been able to include Jung's because their point protocol takes up a half a page of explanation in their publication, so it doesn't fit into this easily. So we have some limitations on the studies, small sample sizes, there's a lack of control, there's only 1 RCT. The studies don't differentiate between stage and length of time of lymphedema. Measurement of limb volume varies. The length of follow-up varies. I didn't point that out, but there's very short follow-up on these studies. And none of them take account of the fact that lymphedema is variable and can fluctuate. So sometimes things look really positive, but they might just be the natural progress of the disease. On the plus side, we're showing that recruitment is possible and acupuncture is acceptable to recipients. And that's important because particularly with breast cancer patients, they're told very strongly to avoid needle puncture, and they're often very anxious about coming into an acupuncture study. We're seeing improvements in quality of life measures, and this is important. So there's a thing, even if we don't reduce volume, we can make changes in other ways with acupuncture. And overall, acupuncture is well tolerated, and there are no related major adverse events. So that's positive. I'm just going to use my last couple of minutes to talk about possible issues to research. So obviously safety is the first thing that we want to be concerned about. And this is the question that not only intrigues acupuncturists, but really everyone in the lymphedema community. What is the real risk associated with this inserting needles into the affected or at-risk area? And is it possible to design a study to assess this? Sharon Kilbraith's team in Australia tried to design a study to assess this, but they couldn't get it approved because of the safety concerns. So can we actually do this, and would we actually want to do this? Would it be ethically acceptable to start needling into an affected area and seeing what would happen? And what would be the implications, particularly for acupuncture, if it did prove to be unsafe? And a question I have, because of the way I work, do we even need to needle the affected or at-risk area? We can use distal points, we can use microsystems. I've done some work with lower body lymphedema patients where I didn't needle below the waist and had some very interesting results. So it may not even be necessary to go there. And could we use acupuncture to affect the disease process? So if you gave all your patients post-surgery or post-radiotherapy acupuncture, could that stimulate development of new drainage routes and prevent the buildup of this fluid in the body? Can acupuncture influence other stages of development? If we could give patients acupuncture when they were in the preclinical phase of lymphedema, would that arrest the development of other troubling symptoms? And what happens if you use acupuncture in the early stages, when the fluid is there, but the tissues haven't changed too markedly? And how do we manage our advanced patients where the fibrotic tissue and fatty tissue have developed? And even if you squeeze out the fluid, it's like a sponge. It resorts to its initial volume. Should we be thinking about acupuncture as the cure for lymphedema? When I started off on my first study, I thought I was going to find the cure for lymphedema. And now I'm older and wiser, and you see my gray hair. Or can it be an integral part of management of lymphedema? I think that is really a key area. Is volume reduction the key issue? I've given up now, but I've done a number of grant applications where I'm working with patient advocates who say, we know we have lymphedema, we know the volume is a problem, but we're being managed conventionally. What we want is other stuff. And the funders come back and say, you need to focus on volume reduction. And can we improve well-being of people with lymphedema? And I've had some very interesting results in my study that people feel better when they have acupuncture, and it helps them to manage and cope with their lymphedema much better. There's very little on East Asian medical diagnosis. Stefan Hillier in Germany did a survey of expert acupuncturists to come up with some possible TCM syndromes, but there's very little discussion of this. And my question is swelling the root or the manifestation of the problem? So there's time for some blue sky thinking, and I hope that you will continue this discussion later in the day. These are my contact details if you want to get in touch. That's a typical blue sky in the UK. Thank you very much for your attention.